All right, welcome everybody. Those of you who are on Zoom don't see what's happening in the back here, but we're still gathering a little bit of food for the folks in the room. Thrilled to welcome everybody to this week's Cyber Policy Center workshop. I should say, for me, it's a Groundhog Day a little bit. I've stepped down as co-director of the Cyber Policy Center to start a new center here, or a new initiative here in the law school on AI, so stay tuned for that, which makes today's speaker all the more relevant to all the things past, present, and future that the faculty here are doing. So we are really thrilled today to have Lee Sanders with us. He's the professor of pediatrics and health policy and the division chief for General Pediatrics at Stanford University. Holds joint appointments in the Department of Health Policy, Department of Epidemiology and Population Health, and FSI. Teaches in the Human Biology program and at the d.School here. With funding from NIH, CDC, FDA, and other national agencies, enjoy the funding while it lasts. Dr. Sanders founded and directs the Stanford Health Design Studio, which leverage AI and other novel technologies. His newest venture is an initiative to build AI for population health, applying novel analytic tools in support of frontline public health providers in underserved communities. He directs the Stanford Children's Complex Primary Care Clinic, where he cares for children with serious chronic illnesses, and also provides care at a federally qualified health center that's the main teaching site for Stanford residents and medical students. As is always the case with our Cyber Policy Center workshops, he'll talk for a half hour or so, and then he and I will have a conversation up here, but we welcome you, both those in the room and those who are on Zoom, to submit your questions. Those on Zoom should submit it in the Q&A portion of the on Zoom, and it'll magically appear on my phone as we're talking. So we are thrilled to have you here today. Thank you so much for joining us.
Thank you, Nate, for that warm introduction. Thank you to the Cyber Policy Center. Thank you to all of you in the room and wherever you are in the cyber world for spending your hour with us. Hopefully, I'll be sharing with you things that will stimulate your questions and also your challenges to me. I want to start, let's see if this works. Yeah, with a few disclosures. As Nate mentioned, I do have funding from another number of federal agencies, and if you're reading the papers, some of which have been recently frozen, but we're looking forward to that being restarted. And I do consult for at least a couple AI companies in the Valley. I recognize the privilege and curiosity that I bring to this work, but in addition to welcoming many of you in this room, some of whom I've gotten to work with as doctoral students and postdoc students, much of what I'm presenting to you lends itself to gratitude to my mentors, to my lab, to the students of the d.School, but mainly to the patients and parents that I've learned from about 30 years of doing research in this area. So as Nate mentioned, I'm a physician. I was just in the complex care clinic this morning taking care of patients. I'm a scientist. I'm a leader. And a year and a half ago, very importantly, I became a patient. I was diagnosed with esophageal cancer and told that I had a 40% chance of living 2 years. So to bring us to today, I am thankfully in remission. But many of the things that I experienced as a patient were both good and bad. I was a VIP patient here at Stanford, but I looked left and I looked right, and as I was experiencing VIP care, I was also in some cases being mistreated. Balls were being dropped in my own care, and I was seeing that happening for the many patients alongside me in ways that had driven much of my research to this point, but now it's become a lot more personal. So where I thought I'd start with you is with a real-world story, though, from my exam room. So as I mentioned, I'm still a practicing pediatrician. I was seeing patients this morning. This is a real patient photograph of a real patient actually back before I had gray hairs working in Miami. And we describe this as a fairly average patient for us in complex care pediatrics. Aria is a 4-year-old girl who experienced preterm birth, has intellectual disability, chronic lung disease, G-tube dependence, and other sequelae of her condition. She has multiple medications, subspecialists. In her short life, she's been seen across 3 health systems. Her mother and her sister, pictured there, have chronic condition, and her mother is a low-wage health worker with limited literacy and English proficiency, and the family lives in a small apartment locally. So you might be wondering, well, there's a talk on AI. Where does this come into this? This is what we consider our medically complex patients. These are the 3 to 5% of patients that consume more than 50% of healthcare expenditures. Well, I just want to tell you right now how I employ AI in the care of children like Arya. If she's going to get a chest x-ray, that's often the AI system will read that chest x-ray before the radiologist does. That's one way. If she comes in with a complex presentation of an acute condition, I will often feed it into the secure large language model that Stanford makes available to us. We can choose from various different ones. And increasingly, we're using ambient AI to record those sessions. So it's facilitating the writing of notes and so forth. So you're going to hear a lot about that if you heard from other AI health speakers about the future of AI. But I really take it up a notch from here. We often ask in our research parents of children like Arya to just give us a drawing, show us what their life is like day to day, week to week, in navigating the care for their child. And this is a sample of a care map that has been drawn by a parent of a patient like Arya's. And one thing that's very important for a health and a non-health audience to recognize is that, of course, the child and the family are at the center. But though I'm visiting you from a healthcare system, from the point of view of a patient and a family, the healthcare system is just a quarter of this map in the lower left-hand corner. The other areas that need to be navigated in each of these distal circles are health needs or individual needs that need to be met for this one patient, are other corners, the school system, for example, advocacy supports, social supports, recreation, legal and financial supports. These maps are critical to understanding the human experience of trying to navigate a chronic health condition. And remember, that's just for Arya. We're leaving out of this the map for her sister and for the mother. And the question that gets me up in the morning and keeps me up sometimes at night is, how do we improve population health? What kind of system do we need to meet everyone's needs? So as I share with you my journey into answering these questions, these are the 3 things I want to cover with you today and then have a conversation about. One, are what are the drivers of population health, including health equity? Secondly, what is the evidence for AI to improve population health? And third, what are the strategic challenges and opportunities for AI to advance human health now and in the near future? So as we go to understanding the drivers of population health, I do want to introduce you to my construction of health equity. And before I do this, I just want to mention 2 things. I promised this to my student. There are 3 things I'm not going to do today. I'm not going to tell you that AI is the future, is the solution to everything in health. The second thing I'm not going to do is to try to make stuff up. So ask me questions, but I won't make things up. And the third is, I'm not going to shy away from talking about equity, despite a lot of the executive orders coming down in Washington, D.C. right now. And the reason why I can't is because this is what I live and this is what I see. So here's a map of where we live, and you can see the deliberately drawn red line here around East Palo Alto. And I asked some of my students, we can have this conversation before, what you notice is the difference. The first difference you notice from above is just the green space, the lived space. But the other thing you might notice, that's the QR code is here. You can do this in any community in the country, ones that you were raised in, certainly within the U.S. You can just look at the life expectancy. You know, here at Stanford Children's Hospital, I take care of the newborns. Our division that I direct takes care of all the newborns that are born here. If that newborn goes back to home in one of these green spaces, Atherton, Menlo Park, their life expectancy is 80 years. If, however, they go back from the same newborn nursery and 2 days later land at a home in East Palo Alto, their life expectancy is just a little over 61 years. So those are real data. We can't hide from those data when we look at inequities. We can also take a global approach. I know a lot of you are taking global approaches. A global approach to health equity, you've probably seen this before. The U.S. spends more per capita on human health and gets less from it, so that the x-axis is how much we spend, and the y-axis is the mean life expectancy by country, and you can see whether you can compare us to a lower middle income country or an OECD country. We're not getting as much bang for our buck in terms of inequity, and so those are some of the, in terms of life expectancy, so those are some of the inequities that we see. Who here has heard the saying, as a matter of fact, based on this, raise your hand, that the zip code is more important than your genetic code in your determining your health outcomes? This helps me test the audience. So that's interesting. I don't see as many. So we say this a lot in healthcare because we recognize that social factors are quite determinative. And this is true from an epidemiologic point of view. People are tracking this. I'm a social epidemiologist, so I hold this near and dear, that your physical environment, particularly at birth and even through adolescence, social context, and certainly behaviors determine more than 50% of the variance in pretty much any significant adult health outcome. So that includes life expectancy that I just noted before, but also many of the common chronic illnesses, cancer, cardiovascular disease, and so forth. Whereas a lot of the investment areas in, in the medical school or in biomedicine, molecular medicine, the genome, the epigenome, we call that omics, and health technology that, I was there delivering today, contribute considerably less than that, at least less than 40% of the variance. So that's true from an epidemiologic point of view. But from a mechanistic point of view, it doesn't really go too far to explaining inequities in health outcomes. Inequities are defined by the World Health Organization, parenthetically, which we've now left as a country, as the systematic preventable difference in the health status of people based on their social, ethnic, racial, geographic, as I just presented, or economic status. And what I like to point out is that most of us intuit that what drives that inequity is poor access, right? I mean, I know this from teaching, I know this from my students. Poor access is what we think of as driving these inequities. But in fact, and my mentor, Paul Wise, who helped recruit me back here to Stanford, points out that there are actually 3 ingredients of any inequity. So this is the first framework I'm going to provide to you that might be helpful to some of your research. It's not all poor access that begets health inequities. It actually requires 2 other ingredients. The second ingredient is a high-risk population. So poor access for a high-risk population, high risk of whatever that health outcome is, to an efficacious technology is what is necessary to cause a health inequity. So I'm just going to linger on this for a second. We can talk about this later. What might that look like? An example might be from your own experience. A highly efficacious technology is generally something that has more than 90% proven efficacy. You can think of, in your own experience, COVID vaccines. In my experience, surfactant for preterm birth. What often happens with a new technology is that it goes to the most affluent communities first, rather than the most needy communities first. And that is where inequities start. And if we're not mindful of this, sometimes it unintentionally, something really good comes along, we unintentionally create a disparity. When we're thinking about new technologies, including AI-driven technologies that are growing fast apace, that might be particularly efficacious for a particular indication, we are trying to pay attention to that. That is my public health mindset: poor access, high-risk population, efficacious technology. So, okay, with that framework, let me shift gears a little bit to my view, and it's just my view, of where novel technologies, particularly AI, are beginning to show strong efficacy for improving not just individual health, but population health. So for this meeting, as well as for a recent meeting, international meeting I went to, I did a scoping review to try to stay ahead of this. And I particularly focused on behavioral health. You might say, why behavioral health? I'm a primary care provider, and we're fond in primary care of saying all health is behavioral health. So when we say behavioral health, we're not thinking just mental health. If I prescribe a medication to you, I'm concerned that you're going to be adherent to that medication. That's behavioral health. If your doctor, and hopefully all of your doctors, are telling you to have better nutrition and physical activity and so forth, that's behavioral health. And if we look at where the AI tools have been most effective, independent of or supportive of humans in advancing health outcomes in that range, 80 to 90% efficacy. Here are the three domains that we're picking up. One, I'll generally call coaching. The second is screening and mapping. And the third is treatment. And I give you some examples of this here in coaching. That could be chronic care coaching, early relational health, obesity prevention, screening, particularly for neurodevelopment, mental health, using very innovative tools, and then treatment, particularly in these areas, anxiety, depression, ADHD, and areas I know like autism. So let me dive a little deeper into this. I'll do this quickly because I want to get us to the conversation. Some examples of research I've been involved in. I'll give you a couple that my colleagues have. There's a program called Goalkeeper. We were awarded in 2014 a grant from the National Science Foundation to do AI work in multi-agent systems. Now we think of all AI as being large language models, but in multi-agent systems, to build a tool that would support chronic care coordination. We conducted a randomized controlled trial. A number of other people are doing studies like this, and it looks like digital platforms could really help a provider, that could be a primary care provider, a physical therapist, and a patient or a caregiver set a goal, track a goal, and keep to goal. Very much better than we can without novel technologies, right? Because we're not able to call or meet with people daily, but these tools look like they should be able to improve that. I mentioned surveillance and mapping. Working with the John Gardner Center at the Graduate School of Education, we've begun to link health data with school data to begin to imagine how we could map and support the health of children across the lifespan. So we now have a virtual birth cohort because of this data linkage from birth to 18 for more than 80,000 children in a high-risk community over 10 years. And we're beginning to apply machine learning methods, that's where the AI comes in, to try to understand patterns that might matter to the community. And some of the first things we're picking up are that students born late preterm, which are about 7% of all children, all of us, are at higher risk for really important features that predict poor long-term health, like chronic absenteeism and falling behind in school. And so we're now taking that back out to the community and figuring out how to deploy these machine learning methods in real time to monitor these data for surveillance. The third example, I mentioned obesity prevention as another arm of coaching. There's a really interesting program. It's actually the one I've been involved in for the longest period of time, called Greenlight, where we did intensive community-based participatory research to build a program to support obesity prevention in early childhood. Why obesity prevention? This is the single biggest child antecedent of adult disease. So if we can really reduce the obesity epidemic, which used to affect, when I was in training, about 5% of children, now affects more than a third of all children. If we can stem that tide, we can really have a big impact on child health. So we built these, with good human-centered design, we built these great booklets. Has nothing to do with AI, I know I'm getting there. Booklets, you can see traffic light diet. We put all of the best technology that we had, non-AI technology, around behavior modification into these tools and booklets, and implemented them at community health centers, 5 sites nationwide, at all of the routine visits from birth through age 2 years. And what we found was it worked, but not for long enough. So we conducted a randomized controlled trial, NIH funded. It worked through about 15 or 18 months, and then it really didn't work through the endpoint, which was 2 years of age. So it lifted our spirits, and then it dropped us on the floor. And we looked at this and we said, well, why is this? Well, it's because we stopped seeing patients. We stopped seeing children very frequently, we think, part of it, between 1 year and 2 years of age. Up to 1 year of age, we'll see children 5, 6, sometimes 8 times. Between 1 year and 2 years of age, often once or twice. What can we do? We can work with our colleagues in artificial intelligence and computer science to build a system, build on top of systems they've created prior to this, to build a digital platform that helps parents set goals on their own and track them over time. And so we built this Greenlight Plus modality where was largely actually text message based in English and Spanish, designed with families for them to set their own goals, for parents, largely mothers, to set their own goals, based on these same principles. And sure enough, we just published this at the end of last year in JAMA, which is one of our leading journals. We had significant impact through age 2 years in reducing the rates of childhood obesity. And we think this is a really promising AI-enabled tool to foster obesity prevention. Let me just share a couple other examples that I'm working on with colleagues on this campus. Working with Serena Young's lab, we're looking at something entirely different called early relational health, which is really about nurturing positive relationships between adults and children, and how we can use computer vision technology to give better feedback on the quality of parent-child interaction. This is where you should feel a little spooky big brother coming in. Do we really want these technologies in our home? And I'll talk about that in a second. But we really have found that these computer vision models can improve by nearly 200 times the current standard, which is videotaping a parent-child interaction and having a human coder, often in a lab, try to code them and give some feedback. So these AI-driven models are likely on the pathway to providing real-time feedback to improve both the research and practice of child behavior supports. Last version of this, Dennis Wall's lab, both in computer science and the School of Medicine, has been working for years now, more than a decade, on applying AI to gamified tools to improve both the detection of autism earlier in childhood and supports to do this. Some of these are figures from his work to improve the care of children with autism by essentially training them to have the superpowers they ask for, which are better recognition of emotional cues. So there's a lot of good evidence from his lab and others that might be on the launch pad for improving population health of things that matter, things like autism, obesity, others. So let me shift to a few of my concluding thoughts about what the challenges and opportunities are for AI to advance human health and how together we might be able to approach that. And again, I welcome your questions and challenges to these. So I mentioned these opportunities for health inequity. But I want to talk about 3 areas where the systemic challenges might be greatest. And these 3 areas are in infrastructure, trust, and public policy. I'm going to give you some examples of this and then dive into where I think some of the solutions could be. So for infrastructure, as I mentioned, I particularly specialize in the care of children with chronic health conditions where, depending on how complex they are, the very complex ones that comprise about 3% of the population, but about 15% of children have some chronic health condition, and yet only 30% of them are reporting that they're, fully 30% of them are reporting that their health needs are not met or left unmet. So that's an example of inequity because of issues with infrastructure that I'll get to in a second. Another example is that 1 in 3 adults has low health literacy. I do a lot of literacy-related research, yet more and more of the information that we've been pumping out in health clinics, online, and so forth is too complex for individuals to understand. And then finally, still in this country, more than 1 in 4 children lives in poverty, and those are the children that are at highest risk of needed services. So that's an opportunity for public policy. So how does this overlay with the AI challenges in population health? So this is where I'm deriving this, not just from my scoping review, not just from my experience as a clinician and researcher, but from my peers in computer science, my peers here in the law school, and so forth. Again, I think it overlies in these 3 areas. What we need more of is to address the issues and the challenges of infrastructure. A lot of the problems that the folks in AI, and particularly AI and health, are pointing out are in data quality and data interoperability. Most of the folks still, if you hear them doing research, even in the startup world, around health data, they're using synthetic data, literally fabricated data to test their models. And where they're using actual data, oftentimes the data is quite biased. It tends to be in more affluent populations, for example, or more white populations, rather than more diverse populations, which would bring in the sort of health problems I talked about before. When I talk about interoperability, that's interoperability across different data systems as well as different data types, and that's why I shared with you the example of linking health and school data before. Algorithmic bias, not quite my expertise. Sherry Rose, who I work with at the Health Center for Health Policy, the Health Policy Department, is really much more of an expert on this. But that's really some of the unintentional biases that we can build into the algorithms when we use biased data. Trust is one that I'll linger on. This is more of an expertise of mine. There's a lot of concern about, of course, the privacy of your data and the security of your data and the other informations being used in AI algorithms today, and so we'll come back to that in the discussion. And then finally, public policy. I've been involved in an effort here at Stanford funded by HAI called the Raise Health Initiative, and what seems to be the consensus from that multidisciplinary group is that we need to think very carefully about what kind of guardrails we want on the work that we're doing and what governance structures we need to improve AI innovation for population health. This is just a schematic. I wanted to call out Jill Glassman, who helped to do this work, of an example from our early relational health work of how we're trying to understand the AI trust challenges. So this is, on the right, a little bit of the observational data, on the left, some of the analytic data. So 2 in 3 parents agree with these statements. I trust a computer-assisted coach to notice more quickly when my device use is interfering with my caregiving, or to help me be more aware of my device use around my child. So this gets into the weeds of what we look at in child development. Turns out that the devices in our pockets are getting in the way of us parenting our children. And so 2 in 3 parents are open to these sorts of models. I showed you before this Harmony model that I'm developing with Serena Young's lab, but still 1 in 3 are not. And so we dug a little deeper into that. One thing to notice is that this technology acceptance is fairly highly correlated with a self-assessed problem technology use, but not a self-assessed realization of the way in which, what we call parent technoference, the way in which I think my technology is interfering with my parenting. And we're trying to apply models from health communication, health behavior, in trying to understand what do we do with with supporting the 2 in 3 parents for now who are accepting of this technology. What are we doing with the 1 in 3? How do we support gaining trust, retaining trust? Is that what we want to do as we build these systems? So, opportunities for AI to advance population health. I talked about the problem of the gap between chronic conditions and unmet healthcare needs. This is where coordinated data and data infrastructure is critically important. So improving data infrastructure. Most of my colleagues in computer science and data sciences are very fond of federated or decentralized data systems to help accomplish this. That's easier said than done in healthcare, but that's where things seem to be moving. Around trust, human-centered design seems to be a promising way of going, and I'm going to detail that in a second, to really take lenses such as literacy and language, which I work on, to the moment in order to build more trustworthy platforms. And then public policy. Many of my mentors and colleagues work on this, but we really need to transform these archaic systems of healthcare and public health using the data that we have to answer some of these problems, and being very conscious of the political realities and fiscal realities. So as I alluded to a little bit of this before, what do we need in terms of infrastructure? Better systems, better architecture, and platforms for decentralized coordinated data, more attention to algorithmic fairness. For trust, human-centered design that includes co-design with the most affected communities, and personalization, which is what most individuals are asking for. AI to augment human care, but not to replace human caregivers. Public policy, I mentioned system transformation, regulatory guidelines, and data-driven decision-making. So I just want to mention where I met some of you in this room may have been at the D.School around the corner, the design school, which has really opened my eyes up to the promises and pitfalls of human-centered design, and we're starting to apply this to AI-driven solutions. And so the challenge I take to my design school students every year is to apply human-centered designs methodologies to craft a solution that addresses this inequity problem, improves access to efficacious health technology for everyone at risk. With patients and caregivers as co-designers, we bring them into the D.School. Well, what does that look like? Well, I talked to them a lot about literacy and language, about this conflict between the skills of the population, the complexity of the information, and actionable information. We talk a little bit about how 1 in 3 U.S. adults lacks basic literacy skills to be able to navigate the healthcare system as a challenge, and how yet the standard is to put out information that's increasingly too complex for people to understand. And then I lighten it up a little bit with this comment from my colleague Deborah Roeder at Johns Hopkins, who says this is effectively public health malpractice. We're putting out more and more information that's more difficult for people to consume, that creates more hazards in navigating to healthcare systems, and creates worse health outcomes. We can't continue to do this. How do we redesign things? So I say, well, we do have, we can go back to basics. We don't need to do anything too fancy here. There is excellent evidence from health communication research, from behavioral research, that supporting clear communication works. We can simplify, listen, translate, teach back. So as you're developing these technology-driven solutions, lean on these principles and co-design with the people with limited literacy or language skills that I'm bringing into the classroom for you. So they do this. They come into the classroom. We go to the community health center in Atherton, where I work. We listen to frontline providers, listen to these dear families who are, in some cases, patients of mine or patients of my colleagues. And they design solutions in a 10-week period of time that are brilliant, that are things I would never have thought about. A wedding registry for post-NICU support, a virtual pharmacist, a personalized coach to help you with your child's special healthcare needs that works through text messaging rather than an app. These great solutions. And then, we're at Stanford, these are wonderful solutions. It's the end of the 10-week quarter, and these fall off the cliff. And so what we're building right now is a design studio for AI population health where we can support these solutions and provide an open platform for the development of AI-driven solutions that advance population health, and bring in all the partners you'd want in the room, industry partners, not just healthcare delivery systems, particularly community health centers, but also industry partners. So it's important to help get investment in this area in order to solve these problems. So in summary, again, back to these 3 themes of infrastructure, trust, and policy. It seems clear that it's not just my vision. This is really picking up from my colleagues here in industry and around the country who are working on AI for good, AI for population health, that we're going to need better infrastructure, this decentralized data owned by the individual to support health decision-making both at the individual and population level, that we're going to need to think very carefully about, based on evidence, whether and how we build trust in AI platforms, and how we do this through a co-design approach with individuals from the communities who are at highest risk for poor health. And finally, to be very conscious of the policy environment. As we do system transformation, how much is this going to be AI-enabled or AI-independent? What are the dynamic guardrails we need to sustain effective policy? And how do we enable the transparency and accountability to drive the data-driven decision-making that I think we all want, but that we all, going back to the trust, can trust? So with that, I just want to share, again, with thanks to my colleagues, a moral imperative here. I shared at the beginning that I take this personally now, not just as a clinician and investigator, but also as a patient. There's a moral imperative because every day I witness bad health outcomes, and any bad health outcome is a tragedy. But any preventable bad health outcome is unjust. And I think that's what drives me to work in community with others in order to solve these problems. And so that's why I'm here today, is to listen to your challenging questions and to understand how we build communities together to try to address these underlying problems. I put my email at the bottom, but also the Raise Health link if you want to learn a little bit more about what my colleagues are doing to build AI for health and for good. With that, hopefully I've taken up the right amount of time, so we'll have some time for conversation and questions. So again, thank you very much.
Well, thank you so much. That was wonderful. I know there are a lot of questions in the audience, so I'm going to start just briefly. We usually have a little conversation to start. And then folks on Zoom, please they're already starting to get some questions in there. Let me ask a kind of typical crotchety AI question, which is like, to what extent do you see AI as kind of a difference in kind versus a difference of degree compared to all the other technology that you've seen sort of in the sort of medical field over the last, several decades? I mean, is this a watershed moment, or do you think this is sort of more of an incremental change on what we've seen?
No, I definitely subscribe to this being a watershed moment. And, I look to much higher paid thought leaders than me for this. If you've read Yuval Harari speaks about this from a historical point of view as well as a philosophical point of view, with the possible exception of some of the genetic revolutions coming around with gene editing, and I don't even think that's going to compare to the earth under us is shifting around AI generally, but certainly in healthcare. As a matter of fact, one of my colleagues, Kurt Langlotz, in radiology, says that if you're a physician, AI is not going to replace you, but physicians who can work with AI are going to replace those who cannot. It's a foundational and watershed moment, I think.
Raise your hand if anybody here has questions, and I'll get to you. Let me ask, at a sort of higher level, what is it about what are the sort of buckets of AI innovation that we think are going to have the biggest impact with respect to the population health issues? So before this talk, if you asked me what are the AI health, the most promising innovations with respect to AI and health, I would have thought drug discovery and maybe also some of these other therapies that you're talking about. What I really valued about this presentation is like, yeah, of course that's true, but it's all this other stuff as well, crunching of data to deal with these inequities. And so generally speaking, taking out of the medical field, we think that the things that AI can do through other social systems is to lower the price of certain types of expertise, in this case, maybe virtual doctors, all of that kind of stuff, as well as to new innovations of things that we just haven't had before, whether it's new treatments, to, like I was saying, provide doctors to those who hadn't had before. Is that the right way to think about it here? As you think about the kind of different domains in which we're going to see AI have an impact, is it mainly sort of taking expertise that otherwise was shared by a few people and then making it more available to larger population? Or is that sort of more too limiting?
I'll do my best to answer your question, but one thing I've learned about myself is I'm a very bad predictor of the future. So, take this with a grain of salt. So definitely don't invest based on what I'm about to share. But let's look at what's, I always look at the evidence that we have, what we have right now. So you're absolutely right. For AI in health today, the biggest penetration is in areas where we have lots of data, so radiology and dermatology. It's transforming those fields. We have lots of data. It's we think, going to improve those sorts of diagnostics. We're all benefiting from this, whether you know it or not. You mentioned drug discovery. I think there's a lot of promise there. A lot of the startups, back to investment, are taking advantage of that. Those are not areas of my expertise. When we turn to population health, I do think you alluded to one of these. Workforce capability expansion is one area where I'm quite excited. I'm in primary care. It's great. We're in an urban area. Hopefully your barriers to access to primary care aren't too great. I usually ask that question, how quickly can you get an appointment with a doctor? For this audience, based on your geography and affluence, hopefully it's pretty quick. In most areas of the country and most areas of the globe, it is not that fast. And I actually think it will improve that. My prediction, again, with a grain of salt, is that in a very short period of time, right now it's almost, I think, malpractice not to check the AI before reading a radiograph, an X-ray. Okay, in 2 or 3 years, it might be malpractice not to check your AI before you go in to see a patient, or even for the patient not to check their AI. That's what it's looking like. So I'm very excited about that, and sort of helping to expand the workforce through that, in many parts of the world where we don't have access.
I want to turn to folks in the room who have questions, but I'll say just one thing, speaking as a law professor, which is that there are a lot of parallels in the way we're thinking about the delivery of legal services as well, to deal with sort of legal inequities and, population law, which is to say that, there's all these underserved communities when it comes to whether it's family law issues or client, renter and eviction issues. We've got a big program here in the Rhodey Center on precisely that. Whether it's virtual lawyers or just using AI to figure out, valid claims. All right, let me go right here for the first question.
Thank you for your talk. So I wanted to ask you describe this dynamic that high-risk populations very often have poor access to new health technologies and that can cause for health inequities. But I was wondering what makes AI different in the sense that you perhaps already on the data and the generation side, there's an inequity in having the data not be representative of the entire population. So how does that influence end user access in high-risk populations if the data doesn't necessarily represent them?
I'll just repeat the question since the first part might not have been heard for folks online, which is the question is about how, let's say biases in the data sets and people who might feed into models, how that might affect delivery and the bias and sort of on the end user side.
Yeah. No, I think you point out a very important problem. The challenge exactly is that, as I played out, that we are very concerned about biased data in a lot of the solutions that are being built. And so there's a lot of work here and elsewhere around the world to try to diversify the data so that we can get ahead of the inequity issues. Around the solutions piece, if I'm hearing you correctly, that's where I think that the opportunities are to, for those of us in this room, for those of us listening, to be in the room as we're designing solutions, to try to prevent an inequity that would occur if a solution were to be particularly highly efficacious. So, for example, if a new diagnostic were discovered through this AI work, to make sure that it would get to the people at highest risk. I started doing consulting in the Valley, by the way, because of this. Not to make money. I don't know how much money I make. Stanford allows you and encourages you to do this. But to try to work with the development teams, the people who are coding these technologies, trying to move AI algorithms into the health space. Because by and large, now if you're a developer out there, forgive me, but by and large, the healthcare experience of most of the developers, most of the coders out there is slim to none, the exception of the last time they went to a doctor. And so I feel like the urgent need right now is to keep the voice of experienced clinicians, public health providers, and individuals from these communities most affected in line with this. I'm finding some success. I'm not saying it's perfect success, but I think that's the way to get out ahead of it. I don't know if this is answering your question. Yes, no, yeah, okay, hopefully. Thank you.
Right there, and then over to Tracy over there. Yep.
Yeah. You talked about co-designing AI tools with affected populations and building trust. And then you also separately talked a little bit about the importance of setting up guardrails and governance structures. And so I'm wondering how you think that this co-design principles apply specifically to policymaking in this space. So how should first-hand patient perspectives be incorporated specifically by policymakers who are grappling with trying to set up guardrails? And what might that look like? And I'm thinking, some questions that are popping up, for example, here are questions around, should patients be notified, let's say, of AI use in their care or not, and how, and all sorts of other questions.
Yeah, it's a great question. I'll tell you some of the ways that we're thinking about this, and again, it's not just me working with folks in public health here, population health. Is thinking about other stakeholders to bring into the conversation as we develop guardrails and also the process of revisiting those guardrails. Some of you are much more experienced in policy creation and implementation than I am. But I think you'll recognize, as we do in healthcare, that this AI shift is changing the pace of things. And so we need to have processes where we have faster feedback loops for that feedback to occur. But when I say other stakeholders, this is where we need to expand our view of frontline public health providers. These are, for example, local health department directors or their agency heads. Okay, you might know some of these folks, you might not. You may have experienced some of them better or for worse during the pandemic. Those sorts of folks, as well as individuals from those communities who will be able to inform whether or not these guardrails make sense and will truly be able to help us foster the sort of outcomes that they're responsible for measuring and tracking. So, you know, we all became public health experts in some way during the pandemic in infectious diseases, but they also do this for chronic illnesses and so forth. So will those guardrails really help with that? And then, of course, there are, you know, plenty of existing, this is the nice thing about this country, existing advocacy organizations who know a lot about the areas of interest, whether those are, in my world, disease advocacy organizations based on age groups, or even particular geographies, rural areas of the country we're particularly concerned about. So feedback loops, diversify the stakeholders, inform the policy along those lines. The surprising thing I'm just going to add is I went into one of these Raise Health symposiums where we had a diverse group of people, and I was very excited to go into the area around raising the voice, you know, the sort of stuff that I do, raising the voice of underserved communities. And I sat with some of my peers who have, you know, like me, been around the country, not just around here, but in, you know, Mississippi and Florida and Ohio. And I expected them to come back to this line around community-based participatory research. Let's continue to listen to the community. Of course, we said that. But in the end, they were pointing over here to the law school. They said, we need really stringent regulations, and we need them soon. And we need them to be readdressed. So I hope that answers it. You know, that's why I'm here, is to create these collaborations. And hope that's helpful.
I think just before Tracy starts on that point, which is, in some ways, we're going to have to look to Europe for that. You know, the way that the regulations are being rolled out on the AI Act in what is a sensitive area, you know, this is one of the sensitive areas under the Act, is going to be, you know, they're sort of the first movers on this to give some signal.
Thank you.
Thanks for your talk. I'd like to anchor my question on the second part of your title, a literacy lens. And I like what you said about communication, listening, playing it back, co-designing. But my first question is, would we benefit from expanding the nomenclature of AI? Because it could be a confusing term, like it's AI for radiology, kind of clarifying what that is and not just calling it this one acronym. And then the second is about teaching, and if you have examples of successful literacy campaigns that have worked before. We haven't even successfully taught people to eat well or to exercise well, and then we're moving on to the next challenge. So can you maybe tell us about something that has worked with communities or people that you've worked with that we could maybe emulate?
Yes, those are two great questions. So first has to do with the term AI itself and whether we need to be either rebranding it or keeping it more specific. So I adhere to that. I'm not sure that we need to trip over ourselves doing that. That's not really coming back from a lot of the research work that I do, the population health work that I do. What is coming back is that people want to see, particularly these large language models, so ChatGPT and they're like, being used in real time to translate health communication messages at the appropriate literacy level. So there's some hope for that. That's future thinking, as well as across languages. Examples of how lower literacy is improving outcomes. One of them I presented to you, that green light work was really meant to do that. So that's an example from my own work in obesity prevention. In adult medicine, this has been used very well to improve a number of efforts to improve medication adherence. So there are really good studies for doing that. Scaling those are difficult, but improving medication adherence with a lower literacy approach has been shown in efficacy studies, and now you'll find a lot of efforts regionally in health systems to improve medication adherence. And one other one where it's actually had the biggest cost effectiveness approach is actually in the surgical field of, just giving you an example, we could go on and on, of preparing people for surgery. It sounds like, we know that one of the areas for lost revenue in surgery or surgeries canceled in the morning because people aren't prepared. Let's say they forget and they eat something early in the morning. Turns out that a low literacy approach has been very effective in changing those sorts of behaviors. That's why I mentioned it goes hand in hand with a behavioral approach to health. And we're starting. You can imagine things that might unfold from that in population health, but it's not all literacy. So the last thing I'll tell you is that the most effective campaigns in public health combine a low literacy approach with a marketing approach. So if you think about smoking cessation, where in public health we point to that, everything we've done around smoking cessation, particularly in the U.S. but also in Europe, the most effective campaigns pick off from marketing as well. So we don't just need to be doing this with schools of communication, but also graduate schools of business to do it right. Hopefully that's helpful, Tracy. Yeah.
Right there.
Thanks for a really interesting talk and call for action. So my question is kind of related to an earlier question, but in terms of thinking about data, like bias in data sets, beyond just like underrepresentation of certain groups, also thinking about data quality issues, especially when we're working to bridge data sources from multiple like local or state-based organizations where you may have variation in timeliness or reporting rates, that sort of thing, and then drawing insights from that. How do we, what are certain approaches we can take to mitigate those specific types of issues?
Yeah, there's a lot in that. I trained in social epidemiology and work in epidemiology and population health. We just had a whole conference. I would say a big section of it was on that. Let me try to answer with two thoughts that come to mind that might be practical. One is that, first of all, you're doing it. You're showing up. You're being thoughtful about it. Stay in the room for any place, particularly any effort, new effort to collect new data, to be very conscious about issues of bias in data collection and how to diversify. And most of this goes back to community-based participatory research. A lot of the work in genomics we can learn from. They're really starting to come up with strategic approaches for diversifying genomic data in vast data sets that other people are using by working with Native American communities, by working with local urban communities of color, rural communities, and so forth. So that's sort of proactive. The other piece, though, where I think there might be more promise, in my view, this is why I was talking about interoperability of data, is thinking about existing data, extant data. A lot of the work that I do is health services research and epidemiology takes advantage of that. I think as we continue to decentralize and link data, we might be able to correct for some of those biases. An example is we do a lot of research, for example, on health services research in individual health systems, and it's so biased, right? You can only imagine if we use just Stanford health data. But in California, we have data on every hospitalization of every child. We just brought data here for every point of care use for kids on Medicaid. This is cumbersome, clunky data, but that's population-wide data. And what we start to see from very importantly from a health point of view, is all of the children we don't see. The kids who are not showing up, and for example, not showing up in the academic medical centers that and from that we can see how where more the activity is, using health system data from academic medical centers. We can see the biases more saliently by using extant data and bringing that in. So I hope those two things might be helpful.
Yes, thank you.
Let me jump off of that a little bit to think about this in maybe a more global fashion, which is to think about, all right, if you had to design the optimal data infrastructure, we talked about a little bit, what is it that we don't have today that you think we need to have in terms of information? I mean, that's a great example
Yeah.
in California. I'm thinking about like India right now, which has digital ID, which could, if you have real sort of national, representative records, for the whole health system, it's like, this is where I would think the AI step function comes in, because we've never been able to maybe crunch that much data with those many variables,
So
look at
again, this goes to my dream and some of my colleagues, Ramesh Raskar, who's a colleague of mine at MIT Media Lab, look at stuff, you might see him around here, is thinking a lot about this and how to use decentralized data here globally in India. Again, not an area quite of my expertise, but what he and I envision is exactly those decentralized data systems that make it less, reduce the friction of bringing those data to bear. So, for example, so there are policy solutions. I understand you might know more. You were mentioning Europe. Some Eastern European countries, Estonia is one of them. So, right, you can be proactive from a policy point of view. So at birth, you get a single ID, and it automatically links all of your data. Health, school, financial, et cetera, for security reasons, for security of the individual, for security of the nation and their security and privacy. That's one dream. So that's proactive. And then there are working with existing systems. And so I hope, Ramesh, if you're watching this, I don't abrogate our areas of trust. But he did, for example, for this reason, sabbatical at some of the, I won't name them, but you know the big ones, some of the big leading global health technology companies. And the truth is that they already have this data. It exists. The question is, how do we help them share that with us either in academia or in public health so it's useful for mapping and supporting population health, and maybe even supporting individual health. So the point, the data's out there. The question is bringing it to bear for good.
Wonderful. Well, we've run out of time. Please join me in thanking Lee Sanders. This is absolutely great. Next week, we've got Phil Menzer from University of Indiana, who'll be talking about AI and social media manipulation, the good, the bad.